Well, welcome. This is February 10th, Wednesday morning at 9:45, when we have here at Tustin Longevity our Ask the Doctor Any Questions. This is a time where my patients and the other practitioners here, their patients as well, can go into the chat, which is on the side here. You have to be logged into YouTube to do that. Type in your questions. You'll notice Talon, the operations manager, is not here today. He's in a meeting. So I'm doing this on my own today with Blake. Blake can see those questions and then he'll ask me. He's in the background, but you can certainly send those questions in. We also, I believe, have some emails. If you want to email a question to us throughout the week, you can send an email with your question on this to office@tlcdoctors.com. Is that correct, Blake?
That's it.
Office@tlcdoctors.com. And they'll save those emails and they'll bring them to me on these Wednesday mornings. I don't pre-screen them normally, and so everything here is live. We're not trying to make this be a medical encounter. This is just for general purposes, general responses as to how an allopathically trained standard general practitioner as myself would approach both the natural and the standard of care for practice in medicine for issues. We're all about prevention. Here at Tustin Longevity Center, we're called Tustin Longevity Center because our aim here is to help you have quality of life and an extended life. So with that, I would suppose we could ask some questions then, Blake?
Yeah, we just have one so far, and that is someone inquiring why you not use D-penicillamine, if I'm saying that right.
D-penicillamine. So the question came in as a email to us. Some person had looked on the YouTubes under challenges. A challenge is the term we use when we administer a chelating agent that attracts lead and mercury and aluminum and lead, these heavy metals that we are exposed to in our environment. We bioaccumulate them, and we don't have an efficient elimination method of doing this. And so the rate of accumulation exceeds anything that we're able to eliminate. So someone in the audience has asked, why don't I use D as in dog, D-penicillamine? Penicillamine is just how it sounds. That is a chelation agent. There are several. There's DMSA, D-penicillamine, EDTA chelation. I choose EDTA chelation. There is an organization called ACAM, the American College for the Advancement of Medicine. This started as the Great Lakes GLACAM, the Great Lakes College for the Advancement of Medicine. This started in the 1960s to promote chelation therapy with EDTA, which is ethylene diamine tetracetic acid. It is an amino acid, or like amino acid, that is polarized such that it will attract the positive ions of toxic heavy metals. These toxic heavy metals will then be caught by the EDTA molecule, and they're soluble, and you urinate them out. This has been used and studied ever since the 1930s when it was first developed. It became quite popular for use in medical practice, mostly for cardiovascular purposes and by cardiologists in the Michigan, Illinois, Wisconsin, Indiana region. This was found to be very helpful in promoting reperfusion circulation post heart attack, preventative for heart attack. But D-penicillamine is a different type of agent, And as with any medicine by prescription, and EDTA chelation is a prescription medication, there are potential side effects, and it varies depending on what you use. At ACAM, I am used to teach chelation therapy. Physicians go to ACAM to get training on chelation therapy and to get a test dose of how much heavy metals a person eliminates with a standardized administrative dose. We collect urine over a set period of time. At our clinic here, we only do it for 6 hours. At other clinics, they'll do it for a whole 24 hours. The maximum dose for EDTA chelation is 50 milligram per kilogram as a single dose. This also is dependent on having normal kidney functions, as we test this on all patients to check your kidney function before we administer medications. My experience over the years, and ACAM has taught and certifies physician for the practice of chelation, that EDTA, ethylene diamine tetracetic acid, is the safest. So with that, the vast volume and majority of chelation is done with EDTA chelation therapy. This is what I was certified in and recertified in, and doctors go back about every 10 years and get recertified and updates on this. D-penicillamine is reasonable, but it has been my experience over almost 40 years of practicing medicine that there tends to be more side effects, more flu-like feeling as it's pulled out. It tends to have a focus on certain heavy toxic metals, as opposed to EDTA chelation tends to have a broader spectrum of removing almost all heavy metals. Over the course of 40 years then, I have found that using EDTA chelation therapy is a safe and steady methodology of removing a wide spectrum of the environmental heavy metal toxins that are plaguing the society. You have to remember, a toxic metal like lead can kill you. It can kill children, even a very small amount. It has the oxidative stress that harms the cell membranes, and then that cell membrane is damaged, and you bioaccumulate the toxins and you multiply the damage. And remember, heavy metals are not biological entities. They can't be consumed or eaten up by antibodies or phagocytized by your white blood cell system. They are like knives. Ground glass is another way I explain it to my patients. Heavy metals are inert, inorganic molecules that bioaccumulate and just damage. So removing this reduces greatly your oxidative stress. Anytime you remove inflammation from oxidative stress, you live longer. And so we promote EDTA chelation here at Tustin Longevity Center because we are aware that in this industrialized world, we are using metals and toxic metals in industry and in the use of propelling the cars and the jets and so forth. And so it's in the air that we breathe. That heavy metal lands on the ground. It gets into the soil all over the earth, gets into the oceans. Even if you're trying to grow organic food, it is in the soil, and so those plants will grow up and draw up these heavy metal toxins into them. So you cannot escape it. This, in my opinion, should be something that is emphasized and taught to all medical students in their training about environmental exposures that are at risk for cell membrane damage. And this really is not done. It's well established that EDTA is FDA approved for the acute management of an acute exposure of a toxic level of lead. So if a child accidentally ate a lead-based paint chip or had some exposure in lead pipe or environmental large amount ingested, then the proper thing would be to acutely chelate them with EDTA. So this is FDA approved. Deep penicillamine is also approved for heavy metal detoxification or removal. So the summary and the teaching of this is to say EDTA has a broader spectrum. EDTA is what is promoted by the American College for the Advancement of Medicine. EDTA is well able to cover all these areas safely and steadfastly over a period of time. So hopefully that answers that question.
Great. And yeah, we actually just got a lot of questions in, so let's start trucking through them. So the first one is asking about bilirubin. What is it? What can it mean to have elevated levels of bilirubin?
Bilirubin is a breakdown product of old, damaged red blood cells. And they're processed in the body, and these breakdown products are called bile, and it's stored in your gallbladder. When you eat a fatty meal, this bile then is secreted into the duodenum where the fat is presented, and it emulsifies, so it helps to put a coating around fat molecules to emulsify it and make it soluble, and as it passes through your colon. So we need bile. An elevated bilirubin is not an uncommon thing to see as a healthcare practitioner. There is a syndrome called Gilbert syndrome, where there is a genetic predisposition for mostly Middle Eastern people to have a higher average total bilirubin than, let's say, other people throughout the world, and they might have 0.5 to a 1 increased milligram per deciliter on all their labs. So an elevated bilirubin could also reflect the fact that there is a gallstone in the gallbladder blocking the excretion of the bile, and this backs up and causes problems. That's when you turn yellow and green looking. Your eyes also look yellow. Your liver is harmed by this. And so we have concern, but it is so common to see mild elevations chronically, especially in Middle Eastern people, that it usually is a benign phenomena. What the clinician will typically do is, depending on the presentation of the patient, if they're well otherwise on exam with no complaints, a mild elevation of bilirubin is just monitored, and they repeat the lab depending on how high the bilirubin is to see if it is stable. 2 points make a stable line, but if on the repeat lab there's a climb, then that doctor has to do more investigation as to why. Might include a ultrasound of the abdomen to look for stones. An ultrasound is a pretty benign initial first step to do that's quite safe. Then a repeat lab with maybe some hepatitis screen, a CBC to look at the red blood cell count. Things like this would be then done. So that's the background on bilirubin for the general practice as well. So are there any other questions?
Yeah, we got plenty. This is kind of a couple-parter here. Is ivermectin the best choice to prevent COVID instead of vaccine? Also, what is your opinion on the safety of vaccines, especially the RNA versions?
Is ivermectin better than the vaccine? Is that what you're saying? The question is? Because ivermectin has at least 40, 50 years of general medical practice experience throughout the world, it is a prescription medicine. It's an anti-parasitic medicine to get rid of worms and stuff. And we know its side effect profile, which is very benign. It's a very safe medicine. It's been around for decades. And the research and the randomized clinical trials on ivermectin are so impressive in regards to having impact to improve those patients who have been tested positive for COVID-19 and became symptomatic, and seriously so, with some being hospitalized, where we found that the introduction of this medication, oral medication, was dramatic in producing a significant recovery of these people of all ages and at all sequences of the disease. Remember, there's the asymptomatic preclinical phase of the illness. Then there's the early phase where you have the cold flu-like symptoms. Then you have a late phase where you go into the organ failure and inflammatory cytokine storm. In each of these phases, ivermectin has, on randomized clinical trials, many of them throughout the world, shown dramatic improvement in the individuals with a great reduction in the mortality or death rate of them. Therefore, if you ask me, what would I use, a vaccine or ivermectin? I would have to go with ivermectin because of the history, the low risk side effect profile, and the great knowledge of the randomized controlled trials, of which there's dozens, to establish its efficacy. And with these therapeutics, I don't see the need to take a vaccine that is experimental. You have to realize this vaccine that they're promoting currently for COVID-19 is still an experiment. And with that being an experiment, and we're seeing large numbers of side effects come in within the very first month of administration. The reports I've heard from the vaccine-related injuries, the VAERS report, which is now up about a week, for a week or maybe a week and a half, that VAERS report was down, but it came up a few days ago. And the report is somewhere in the realm of 40,000 in 1 month adverse side effects from the vaccine, 40,000 of which close to, I think, well, I don't know the exact number, but a huge percentage of anaphylactic reactions. And my understanding is now the worldwide death count post-vaccination is in the 500 range. So why would I advise my patients to take a vaccine that is an experiment that has such a dramatic side effect profile in the very first month of administration, to include death, serious side effects of a significant number, as opposed to a 40-year, 50-year-old medication like ivermectin or hydroxychloroquine, use of vitamin D, use of zinc, use of quercetin, use of vitamin C, therapeutics along with Z-Pak, erythromycin, zithromycin, doxycycline. These are things that we have a low-risk profile, and we have quite a few randomized clinical trials, both on hydroxychloroquine and on ivermectin. So I would never want to put my patients at risk. I took an oath to do no harm, and so I can't with good conscience make a recommendation for the vaccine. And remember, it's the experimental vaccine. Hopefully that covers that question.
Great. Jennifer has a question. Is there a natural way to dissolve gallstones at an early stage when they are discovered but before they become symptomatic? I've also read that apples and apple juice can be beneficial.
Well, a week or two ago, the same question came up, so I'll refer you back to my prior YouTube videos. And essentially the answer quickly is no. There is no clear methodology for reducing the size of your gallstone. And I would tell you that a gallstone is usually associated with the obese, over 40, and usually a female. And lifestyle is part of this issue. So we promote a low-carb diet. We promote anti-inflammatory, healthy, good hydration, not eating late, systemic enzymes, anti-inflammatory, and and a large single stone in the sac is never going to pass through the tiny cystic duct. And these tend to be less problematic stones, and people can live with that. Usually, when I have a patient that comes to me and has a large gallstone, I will advise them that this is probably not going to be a problem. They could electively choose to have this removed. I do advise them to see a general surgeon who will then give them their experience, because that's their specialty, as to the pattern and management of a large gallstone, single gallstone. But when there are multiple small stones, tiny stones, the probability of one of those small stones getting stuck in the duct of the cystic duct becomes very more likely. And if that gets blocked, it could create severe sudden pain, inflammation, infection, and even death. So I would like all my patients who we happen to find have a gallstone or gallstones to have at least one consultation with the general surgeon, so that they're familiar with the patient, should the patient want to elect to remove it, or if they choose not to remove it, that surgeon is aware of their situation and would be familiar if they ever had an acute episode and how to manage them. So no, these methodologies of drinking various cocktails, liver flushes that promote a high fatty drink that forces that gallbladder to contract and squeeze is not something that I've ever seen in 40 years to have any benefit whatsoever, and that goes for the liver flush as well. I see far greater benefits in the ketogenic type low carb diet, not eating after 6:30 p.m., regular exercise, plenty of water, half your weight as ounces consumed every day, taking enzymes, anti-inflammatories, using probiotics and other select tailored nutrients, rather than these rather bizarre and fringe therapies. I know people are on the internet and they claim they see these things in the bowl of the toilet after they do a liver flush, and they see these little round greenish looking marbles. That's just micelles. Micelles is the chemistry name for globules of fat globulus. These are not gallstones. So I would caution you away from that and just tell you, sadly, these items that say various acidic juices help dissolve them away. There is no clinical experience or scientific evidence of respectful nature that we can endorse that with. And I would encourage you, if you have a gallstone, to see your doctor, see your general surgeon, and have that followed.
Great. Some more questions. Is it safe to buy Juice Plus if one has had an allergy to one of the ingredients, broccoli? Is there a way to test for this before beginning with Juice Plus?
In general, these questions about food sensitivities refer to the immunoglobulin G, not immunoglobulin E. Immunoglobulin E is an anaphylactoid immediate hives reaction. You would know this, and you would have learned this by your adult age, to avoid those foods. When we do IgG studies, for instance, if I eat a lot of broccoli myself and I do my immunofood allergy test, I will come up with sensitivities to broccoli if I overeat it, or to Brussels sprouts, or to spinach, or to green beans, and so forth. So what I'm telling you is these immunofood allergies that have IgG food sensitivities are not a contraindication to the 30 different fruits, vegetables, and berries that are in the Juice Plus. And we would encourage you to understand also that food allergies usually are referring to the lectin, the outer coating structure signature on the outside of the food item. This is a material that is designed in nature to repel fungus and bugs and so forth, because the plant can't run away from funguses and bugs and so forth. So they usually have on their outer coating of these fruits and vegetables and berries a noxious material called a lectin protein in the coating of that fruit, vegetable, or berry to repel fungus, to repel insects, to repel predators, okay? And when we eat these lectins, these are what can irritate us. I want to remind you that the foods that we eat should be on a rotational basis, so that, let's say you do have tomato, and tomatoes skins have a lot of these lectins that are very noxious to our system. If you eat them infrequently, let's say once every 4 or 5 days, the likelihood of you developing any bodily systemic problem from it is very much lower than if you're having ketchup every day on a hamburger, spaghetti pasta, you're having calzones or some kind of tomato-based product all the time. So food allergies and food sensitivities are two categories. One's an immediate anaphylactoid IgE, and the other is a IgG slow reacting from excessive consumption day after day after day after day. So no, this is no contraindication for the using of the Juice Plus.
Great, and we have 2 more so far. One is just a follow-up to the ivermectin question. They want to know if you prescribe it as preventative.
Yes, I've been prescribing this as a preventative for my patients that request it. And what was the follow-up?
That was the follow-up from the ivermectin question.
The other one, okay.
And then the next question, which is the last one right now, was what are the symptoms of heavy metal in the body, and should most people, especially in metropolitan areas, get tested for heavy metals?
We have very good studies over the past 60, 70 years showing evidence that urban children who are constantly breathing in a higher part per billion concentration of heavy metals, lead in the air and so forth, we know that bioaccumulation of lead leads to irritability mentally, poor mental focus, and violent behavior. So if you go to delinquent centers for juveniles and you do serum blood testing consistently, you will always see that those that are in these centers, these children have higher lead levels. So the answer is yes. Oxidative stress to the nervous system and the brain is very irritating. It limits the mental IQ, and it makes toward emotional behaviors and violent behaviors well established in the psychological industry and in the toxicity industries. They've proven this all over the place. Wherever there is a city, urban center, and children are studied for their truancy, and juvenile centers as well. So did that answer that question?
Yeah, I think so. And then one more did just come in. We probably only have time for this last question, and that is from Donna saying, if you already had COVID, would you suggest getting the vaccine at some point in the future? I had COVID 3 weeks ago and it was not pleasant.
I cannot endorse an experimental vaccination at any point for the reasons I've listed. We have so much valuable preventative, immune-enhancing, immune-building lifestyle and supplementals recommendations such as quercetin, zinc, vitamin C, vitamin D, the low-carb lifestyle, getting a good night's sleep, staying hydrated, and having a positive attitude. You know, fear and anxiety is immunosuppressive. Along with ivermectin, along with hydroxychloroquine, and these other therapeutics. So at no point would I recommend the vaccination at this time with what I'm seeing about the side effects and the deaths and anaphylactoid reactions coming in at this rate.
We are pretty much out of time, but there's a couple more questions. Maybe we can try for this last one. And this person's just asking how long you think COVID immunity may last.
How long do I think COVID will last?
If you have COVID, then how long would your immunity last after that?
Typically, when you get a viral infection, you develop antibodies to that family. And I think it's well established now that the coronavirus family, of which there are many coronaviruses, there are some people who are already immune, even if there is this COVID-19 virus presenting itself. And so we're starting to see even both sides of the immune system, the adaptive and the innate, the T cells are able to protect certain people. So our immune system is quite remarkable. And with that, many times we'll see lifetime immunities from viral exposures. It is to be determined if we're going to identify or try and identify this COVID-19 variety or group, how long that will last. It's generally said in the research and by virologists and microbiologists that it's anywhere from 2 to 6 months, possibly a year. But again, they'll say the same thing. We don't know yet, but there are many times you get lifetime immunity.
Great, and a couple more questions did come in, but we are out of time. So any final words to the audience?
Well, we are having a Mona Lisa Touch special, and Valentine's Day is coming up, and so that is a very special situation we're doing to help in our way with Valentine's Day coming up. Mona Lisa Touch is designed for women to enhance vaginal and tension, so to say, and tightness, and stop incontinence of the female incontinence. And so we have a really nice price reduction and so forth. And then we have a cardiovascular health promotion package that we're promoting. So see the website, TLCdoctors.com, and look for those. Look on your email. If you're not on our email list, call in the office, give us your email. And we'll look forward to seeing you next week, Wednesday at 9:45 in the morning for a live Ask the Doctor Any Question. Again, this is not meant to be personal medical advice, but general information. And I hope you have a great week until then. God bless.